from Dr. Adel Hussain. Dr. Adel is graduated from Cairo University in 1992. Yeah, he got his master's degree in critical care 1997 from Cairo University, MD and PhD critical care 2 from Cairo University. He was a former assistant professor of critical care medicine in Cairo University, and currently he's a critical care consultant in King Abdullah Medical City in the holy capital Mecca. He will speak tonight about a very talk. For me, at least, it's a very interesting talk about what's called tumor lysis syndrome. Dr. Adel, can you hear us?
Okay, yes.
Yes, please, you have the mic.
Okay. Thank you, Dr. Muhammad, for your introduction. أولاً بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الله والمرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. اللهم اجعل عملنا هذا صالحا ولوجهك تعالى خالصا وانفع به. My appreciation for receiving live course, Dr. Walid Habashi and the organizing committee for giving me this opportunity to be with you tonight. The topic of my presentation tonight is about the crisis of cell lysis, or the so-called tumor lysis syndrome. So within the next time frame, inshallah ta'ala, I will highlighting the review of the tumor lysis syndrome. Just before going to my lecture, and because of the slander and defamation talk and speech coming from France against our messenger and Prophet Muhammad sallallahu alaihi wasallam, peace upon him, just we are introducing the Prophet Muhammad sallallahu alaihi wasallam, peace upon him, in the eyes of non-Muslims. So this is the words from the Irish writer Bernard Shaw in 1936, and this is what he said, that he called Prophet Muhammad, peace upon him, that the savior of humanity. This is Mahatma Gandhi from India, and this is what he said about Prophet Muhammad, peace upon him. And this is a famous book by Michael Hart, wrote in 1992, that he ranked 100 of leaders who named his book that 100 ranking of the most influential persons or leaders in the history, and he chose Prophet Muhammad sallallahu alaihi wasallam top of the list. And this is his introduction to his book. He said, my choice of Muhammad sallallahu alaihi wasallam to lead the list of the world's most influential persons surprised some readers and maybe questioned by others, but he was the only man in the history who was supremely successful on both the religious and secular levels. So Prophet Muhammad sallallahu alaihi wasallam, messenger of Allah, deserved to be respected from Muslims before Muslims. Regarding the disclosure of my talk, I have nothing to disclose tonight in my presentation. The objectives of my presentation tonight will turn around identifying the risk factors and the pathophysiology for the TLS, or the so-called tumor lysis syndrome. Second, to describe the preventive strategies and consideration for patients at risk of TLS. And finally, we'll discuss the current evidence or evidence-based medicine for management of TLS. Just a case scenario, and I will highlight the questions, then you can submit your answers in the chat, please. So this is a 30-year-old woman presents with abdominal pain and paresthesia. She was diagnosed with CML, or chronic myeloid leukemia, 2 months previously, and she was treated with chemotherapy a month prior to her presentation. These lab results, when she presented to the ER, her sodium 131, potassium 6.6, chloride 101, bicarb 13, creatinine 270 millimole. GFR is 19, urea 34, calcium 0.9, phosphate 4.4, magnesium 1.3, albumin 32, LDH was 947, urate or uric acid was 2. So the questions are 3 questions here for this scenario. Describe and interpret the test results. You just saw it. Second, what's the pathophysiology explanation of the key abnormalities in these lab results? Third, what are the risk factors for this condition occurring? Just back to the labs. Okay. Case number 2, Mr. PK is a 31-year-old male, about 62 kg, recently diagnosed with ALL, or acute lymphocytic leukemia, with a baseline W count of 1,400. There was no significant past medical history. These are the lab results: serum creatinine 0.8, potassium 4.2, total calcium 9.1, uric acid 4.4, LDH 960, his phosphorus 3.7. The question is, how would you classify Mr. PK risk category? A is a negligible risk, option B, a low risk, C is intermediate risk, D is a high risk. Back to the scenario. So stratify the risk, please. Based on this case scenario, what's your risk stratification for his primary disorder? Is there negligible risk, low risk, intermediate risk, or high risk? So what's the background of tumor lysis syndrome? Tumor lysis syndrome actually was described old in the past, dating 1929, in patients mainly with chronic leukemia. It's an oncological emergency. As you all know, when you heard types of oncological emergencies, so you should mention first of those emergencies is the tumor lysis. So it's an oncological emergency caused usually by rapid and massive breakdown of the tumor cells. It happens either spontaneously in up to 1/3 of tumor lysis cases, or after the initiation of chemo or cytoreductive therapy. So this oncological emergency is the tumor lysis either happens spontaneously or happens after the initiation of the chemotherapy. And 1/3 of patients develop tumor lysis, it happens spontaneously. And we will see later on why it happens spontaneously. Usually it occurs in patients with bulky, rapidly proliferating, and treatment responsive tumor. This is very important criteria for the tumors that have the risk or the high risk for developing lysis. Those tumors usually are bulky, tumors are rapidly proliferating, and those are tumor or chemo responsive. Although the tumor lysis can potentially occur with any type of malignancy, but it's most commonly associated with acute leukemias and the high-grade non-Hodgkin lymphoma, namely the Burkitt lymphoma. This is the commonest 2 types associated with the development risk of TLS. The rapid release of the intracellular ions and metabolic byproducts into the systemic circulation, it will lead to hyperuricemia, hyperkalemia, hyperphosphatemia, and secondarily hypocalcemia. And of course, these metabolic abnormalities can lead to or can cause significant morbidity. Why? Putting the patient at a risk of severe clinical consequences like acute kidney injury, arrhythmias, seizures, and even cardiac arrest. So tumor lysis epidemiology in children with acute leukemias receiving induction chemo, the so-called silent laboratory tumor lysis in about 70%. So it's quite important incidence, quite high incidence, especially in kids with acute leukemias who will receive induction of chemo. So 70%, they may develop the so-called silent laboratory tumor lysis. About 3%, they will develop clinical tumor lysis. We will say later what's the differentiation between both entities or both types. In one of the retrospective analysis, including about 700 adults and kids, 37 were non-Hodgkin lymphoma, 36 were EL, and 27 were EML. So again, acute leukemias and non-Hodgkin lymphoma having the high risk. The clinical tumor lysis syndrome was about 5%. Of patients who develop tumor lysis, what about this morbidity or kidney injury? Almost 45% they had AKI, acute kidney injury. 25, they require dialysis with different modalities, is a CRRT or intermittent hemo. 15%, they died because of the tumor lysis complications, cardiac arrhythmias, seizures on the airway issues, the cardiac arrest. So it's quite important to know about this epidemiology regarding the incidence, the mortality, the morbidity. This is one of the studies conducted in 2008, though reported in the two age groups, in the adult and the pediatric age group, the incidence of developing tumor lysis syndrome among the common malignancies. So here for acute leukemia or ELL or EML in the pediatric age group were the highest. For non-Hodgkin lymphoma, it comes the third, and solid tumor, it was the fourth in the rank. While in the adult, ELL, EML, but comparing the EML was highest compared to the pediatric, so the EML has the highest risk. The CLL, or chronic lymphocytic leukemia. Regarding the lymphoma, yes, the non-Hodgkin lymphoma in the adults was the highest rank, the multiple myeloma also in the list. So these highlights the risk overall about the tumor lysis in the leukemias and the non-Hodgkin lymphoma. For the pathophysiology, it's easy to understand why tumor lysis syndrome develop if you know the mechanisms, if you know the pathophysiology. So it's easy to prevent, easy to treat. So all of us, we know that the malignant cells, whatever the tumor, either lymphoma or leukemia, with the burden of the tumor, there is a release of the intracellular content, which is our proteins, DNA. So there is, and the electrolytes or the byproducts. So uric acid, one of the purines, the potassium, and the phosphorus. Those released in the presence of volume depletion or hypoperfusion or hypotension with the urate crystals or calcium phosphate crystals, this of course will develop AKI. If this AKI was not addressed or not treated early, and the patient will develop oliguria or anuria, then of course you will have hyperkalemia or hypocalcemia, or both, which will develop, and the patient will develop subsequently cardiac arrhythmias or cardiac arrest if you have untreated AKI. On the other hand, because of the oliguria and the volume overload, so the patient will develop volume overload, pulmonary edema, and respiratory failure, then he will require intubation. There is an aggravating risk factors for developing the tumor lysis syndrome. So this is the main pathophysiology, is the turnover or the release of the intracellular content. But in the presence of aggravating factors or predisposing factor, the risk will be more high. like, for example, if the patient has hypoperfusion or hypotension, patient has sepsis, he received IV contrast, nephrotoxic medication on board, if the patient has heart failure, had baseline CKD or chronic kidney disease, the tumor itself, the lymphoma or else, is infiltrating the kidneys if he has an extrinsic also urinary obstruction. Those are aggravating factors that increase the risk of tumor lysis syndrome. So asking ourselves now, what's the mechanism of AKI, or acute kidney injury, in tumor lysis? Mainly the catabolism of the nucleic acid from the cells, and this catabolism to uric acid, it will lead to hyperuricemia. Okay. The increase in uric acid excretion through the renal tubules, it will precipitate in the renal tubules, and it will cause renal vasoconstriction. It will impair the renal autoregulation and will decrease, of course, the renal blood flow, and it will lead to AKI. On the other hand, the hyperphosphatemia with calcium phosphate crystal deposition in the renal tubules will be the second mechanism for developing AKI. So high concentration of both uric acid and phosphate crystal will potentiate the risk of AKI. Why? As we told you, that the uric acid precipitates more readily in the presence of calcium phosphate and vice versa. So this is, it's like a complementary mechanism for developing the AKI. Regarding the morbidity and mortality for tumor lysis, 30% to 35% of the affected patient usually they will require renal replacement therapy. Those who develop the tumor lysis, about 30 to 35%, they will require renal replacement therapy, either CRRT or intermittent hemodialysis. The overall mortality is greater than 15%. The tumor lysis syndrome, per se, is independent risk factor for AKI and increase the 90 mortality for patients who develop tumor lysis. They evaluated that 6-month mortality in patients with tumor lysis, and they found something interesting statistic, that those who develop AKI, tumor lysis with AKI, they have 6-month mortality is about 66%, so it's quite high. While those that did not develop the AKI mortality, 6-month mortality with about 20%. So this is address the importance of managing or preventing and managing earlier the AKI in the milieu of tumor lysis syndrome. Now, for the definition of tumor lysis, Cairo Bishop is the famous one, or the famous names who put the definition of tumor lysis syndrome. So Cairo Bishop, the definition states that we have 2 definitions or 2 types of tumor lysis. We have laboratory tumor lysis and we have clinical tumor lysis. So what's the difference? Laboratory tumor lysis, any 2 or more of the values we will highlight it later on, any 2 or more of these values within 3 days before or 7 days after initiation of chemotherapy. So if we have 2 or more of these values elevated within 3 days before or 7 days after initiation of chemotherapy, this is, we call it laboratory tumor lysis. This is a laboratory definition. So compared to the clinical definition, clinical tumor lysis is a combination of both the laboratory plus at least one of the features that characterize the tumor lysis as a sequelae of the laboratory tumor lysis. So laboratory plus one or at least of these clinical events. So we highlighted now as a clinical, or we will describe it now as a clinical tumor lysis. So here is the discrimination or the differentiation between the laboratory TLS or clinical TLS. Based on what? Based on 4 metabolic abnormality, 2 or more. So if I have, as I mentioned, 2 or more of those values for electrolytes or metabolic derangement within time window, the 3 or 7 days. So hyperuricemia, hyperphosphatemia, hyperkalemia, and hypocalcemia. And these are the triggers or the definitions. Hyperuricemia more than 8 or 25% increase from the baseline. So I should have the baseline for my patient. Hyperphosphatemia, more than 4.5 in adult or more than 6.5 in kids, or more than 25 increase again from the baseline. Hyperkalemia, more than 6 or 5 increase from the baseline. Hypocalcemia, less than 7 or 25 decrease from the baseline. These are the laboratory criteria. While for clinical criteria, we will have one of these metabolic derangement plus the clinical event for like cardiac arrhythmias, or because of the hyperkalemia, widening of the ECGs, bradycardia, cardiac arrhythmia with hypocalcemia that results from hypocalcemia, seizure, neuromuscular toxicity. So those are clinical events related to the increase in the potassium or in the decrease of the hypocalcemia. And Cairo-Bishop clinical grading or risk factors, they graded from 0 to 5 based on the creatinine, the cardiac arrhythmia, and seizure. So again, they stratify the grading the rest based on serum creatinine, the presence or absence of cardiac arrhythmias, the presence or absence of seizure. And they grade from 0 to 5 in between. So here you can stratify based on creatinine or cardiac arrhythmia, 2 or 5 if there is those 4 or 3 parameters, which is the creatinine, cardiac arrhythmias, and seizure. Now, what are the risk factors for the tumor lysis? Which is very important to know the risk factors, because if you know the factors, so the occurrence of the tumor lysis. So for risk factors, we group it under 4 categories, and we will describe it one by one. First is the issues related to the cancer mass itself. Second, for the cell lysis potential. Third is patient features. And fourth is the presence or absence of supportive care in the oncology patients. So we will start for the risk factors related to the cancer mass. As we mentioned before, all bulky tumor, extensive metastasis. So those are at high risk. So estimated here by the blast cell count or the LDH burden. The organ infiltration by cancer cell like kidneys, spleen, and liver. Bone marrow involvement, renal infiltration or outflow obstruction like obstructive neuropathy because of the kidney infiltration. So this is a risk factors for developing the tumor lysis, either spontaneously or before or after induction of chemotherapy. Second is the cell lysis potential. So for high rate of proliferation of tumors, they are at risk of a high risk of developing the tumor lysis. How can you assess the high rate of proliferation? Through using a surrogate marker, which is the LDH assay or LDH level. The cancer cell sensitivity to the chemo, we call chemo-responsive. So many hematological malignancies are chemo, like AML, EML, are the intensity of the initial anti-cancer therapy are using 1 tools and what line it contains. So the intensity, this chemotherapy regimen also put the patient at the risk of the tumor lysis. Third, what about the patient features? If the patient has underlying nephropathy or CKD before the diagnosis of his malignancy, if the patient had volume depletion, if he had a baseline of increased uric acid or high or hyperuricemia as a baseline, hypotension, or exposure to contrast or nephrotoxic medication. This is patient feature that put the patient at high risk for TLS. Last but not the least is the supportive care for this patient. If he has inadequate volume resuscitation or dehydration, he had exogenous potassium supplement, exogenous phosphorus supplement, or he has a delayed intervention to remove the uric acid from the start if they have a baseline hyperuricemia. For, as we mentioned, for risk assessment is very important to assess the tumor lysis. So you have to assess the cancer stage, the LDH level, the white count, the likelihood of realized at the initiation of therapy. As we mentioned, we have silent and we have clinical. For the clinical, it is higher at the initiation of chemotherapy. The highest risk of malignancies that labeled to have high risk of developing TLS, advanced Burkitt lymphoma, leukemias, the ALL with white count more than 100. So if you have a count more than 100, so now there is a high risk. If you have EML with white count more than 50,000, this is a high risk. If you have a diffuse large B-cell lymphoma per se, is a high risk. And bulky diseases, so whatever the bulky tumor, solid tumor also is at a high risk. Either they will develop spontaneously or after initiation of chemotherapy. And here, a nice diagram how to assess the risk between low risk or intermediate risk or high risk, and you manage accordingly to this risk assessment. So if you have a malignant disease, so this malignant disease is hematological malignancy or solid tumor. If it's a solid tumor, this is a low risk disease. If it is a hematological malignancies, we develop it. Either AML or ELL per se, this is a high risk disease. So EML or ELL per se is a high risk disease. If it is a lymphoma, lymphoma has, it depends on the grade of lymphoma between intermediate or low or high risk sometimes. Multiple myeloma per se is a low risk disease. About the chronic leukemia for CML, the chronic phase, it's a low risk disease. But for CLL, if you are using a therapy with alkylating agent, it's a low risk disease. This alkylating agent is a type of chemotherapy. For CLL or chronic leukemia, if you have a targeted or biological therapist, this is an intermediate risk disease. So this is a graph just summarizing the risk assessment based on the type of malignancies, hematological malignancies, tumors, and the hematological malignancies are acute leukemias or chronic leukemias or multiple myeloma. And here is the risk stratification between the non-Hodgkin lymphoma, the acute leukemia, the CLL, and others. For non-Hodgkin lymphoma, if you have Burkitt lymphoma, lymphoblastic lymphoma, BALL, or you have acute leukemia more than 100,000, or EML more than 50,000 monoblast, this is a high risk of TLS. It should be addressed earlier. If you have a diffuse large B-cell lymphoma, while in acute leukemia, the count between 50 to 100, EML between 10 to 50, and CLL between 10 to 100, and there is fludarabine treatment, this is an intermediate risk. While the low risk for the indolent non-Hodgkin lymphoma, for the ELL less than the count less than 50,000, and the EML the count less than 10, and for CLL the count less than 10,000. This is a low risk. So for the risk stratification, we have high risk, intermediate risk, and low risk based on the tumor type and the tumor description and the tumor stage. Here for the clinical presentation, of course, the clinical presentation will depend on the complication or the events of this clinical tumor lysis syndrome. So the clinical presentation related to hyperkalemia, clinical presentation related to hyperphosphatemia, clinical presentation related to the hypocalcemia, clinical presentation related to the hyperuricemia. For example, if I have hyperphosphatemia, if severe hyperphosphatemia untreated, the patient may develop with EKI, acute kidney injury, altered mental status, severe gastric abscess. For hyperkalemia, of course, he will present with ECG abnormalities, symptomatic. He will start coming up with easy fatigability, and to the extent he may come to the ER with cardiac arrest. Hyperuricemia, he will come with, or he will be present with EKI. Hypocalcemia also, this severe, he will present with altered mental status, severe arrhythmias, and tetany. And this is the definition. I know all of you know about the definition of EKI, and it applies the same definition with rifle criteria and the acute kidney injury network criteria to apply for definition of EKI using the serum creatinine and the urine output. Now moving to the tumor lysis syndrome management. To manage the tumor lysis, we have on board 2 guidelines. One guideline published almost 12 years back in 2008. This is what the first one for evidence-based management of tumor lysis by the American Society of Clinical Oncology. Then there is a British Society of Hematology issued in 2015 the guidelines for managing the tumor lysis in the adult and in kids. And this is what the latest we have. So we have one from 2008 by the American Society of Oncology, and we have one in 2015 by the British Society of Hematology. And as Benjamin Franklin said in this very famous quotation, that an ounce of prevention is worth a pound of cure, of course. So prevention of tumor lysis, there is a significant effort should be focused on, of course, prevention of dysrhythmias, prevention of neuromuscular abnormalities related to the hypocalcemia and the hyperphosphatemia, maintaining the appropriate renal function. They studied the uric acid level and the progression to tumor lysis, and they found that uric acid level 4 or equal to 8 versus 4 to 8, and 4 to 8 versus less than 4, with a significant importance of risk progression of tumor lysis, that they found that the tumor lysis development or occurrence, it increased about close to 1.05 fold for every 1 milligram per deciliter increase in the uric acid. So for each increase in the uric acid level from the baseline by 1 milligram, there is an 1.7 fold increase in the tumor lysis syndrome. What about the hydration as a cornerstone in the prevention of tumor lysis or management of the tumor lysis? So the aggressive IV hydration is considered as one of the cornerstones of preventing the tumor lysis, and it is recommended by all guidelines for both intermediate and high-risk patient with tumor lysis. So from the previous slides I showed you, you should identify that the risk either low, intermediate, or high based on this. Aggressive, and I will tell you how aggressive later on. So the aggressive IV hydration is recommended for all patients at intermediate or high risk of tumor lysis. There is several benefits, of course, beyond the intravenous hydration, to promote the excretion of uric acid and electrolytes, to decrease the calcium phosphate crystal formation in the renal tubules, and to maintain the renal perfusion. The patient should be monitored and should be admitted to the ICU, especially if there is an EKI or EKI on top of CKD. There is a cardiac dysfunction. because this patient needs a volume resuscitation and he should be monitored in the ICU. And the patient is already edematous. So those three categories from the start should not be managed in the floor. They need to be managed precisely, objectively, with a volume status assessment like point of care ultrasound, so you can judge precisely and objectively this patient is already resuscitated well or not. So those patients usually with underlying AKI, patient with heart failure, patient who's already edematous or already with oliguria. Prior to initiate the IV hydration, all reversible factors like urinary tract obstruction causing the AKI should be corrected, of course. Timing of IV hydration, it should start 24 to 48 hours before the chemotherapy. So any patients at intermediate or high risk of developing TLS, he should start up to 48 hours of proper or aggressive IV hydration. The guideline recommends about 2 to 3 liters per meter square body surface area per day, or 200 ml per kg per day in kids weighing less than 10 kg for both kids and adults at a risk of TLS. So you can here look for the rate. So it's up to 200 ml per kg per day. Those for kids and adult, 200 is for, for kids less than or equal to 10 kg, but for kids or adults more than, of course, kids more than 10 kg, so you will go for 2 to 3 liter per meter square body surface area. The urine output should be closely monitored and maintained at least 2 ml per kg per hour for both kids and adults, and 4 to 6 ml per kg for kids live or equal to 10. So the normal urine output is not followed here. We need a higher urine output because we are giving aggressive volume status. This patient, we mentioned that he has a borderline ejection fraction or compromised cardiac status. So here you should go less aggressively. The choice of the IV fluids depends on the clinical circumstances. The guidelines suggest that the initial use of D5 quarter saline was all patients receive these the remission actions, acute lymphocytic leukemia or ALL patients, they will receive usually steroids during the remission induction. So this is to low sodium retention and hypertension, sometimes hypernatremia. We start with D5, recommend D5 quarter saline. Unless it is basically natriuretic, so or volume depleted, so the isotope saline should be the fluid of choice. Due to the risk of hyperkalemia and the hyperphosphatemia with, of course, the calcium phosphate precipitation, once the pregnant is, potassium and calcium should be on hold from the hydration fluids and should be logged immediately. There is no plan at the duration for how long. It depends on the tumor burden, the type of chemotherapy used. Some regimen induce the tumor lysis several days later after induction, not immediately. The drug sensitivity of the tumor and the patient ability to drink, and of course the renal function. The IV hydration or the IV hydration will be continued until tumor burden is largely resolved. How can you assess? This is indicated by the blast cell count as well as the liver spleen size in leukemia patient, and to monitor the serum LDH or the tumor size in patients with solid tumor. So those are the markers or the surrogates that it will tell you that the tumor burden is largely resolved. Second, there is no evidence of significant tumor lysis as indicated by valorization of uric acid, level and the phosphorus level. Third, the patient can tolerate oral intake adequately and he has a good urine output. What about the use of diuretics for prevention of tumor lysis? Diuretics can be used to maintain urine output when, if necessary, the patient is allegoric, is not responding to aggressive eye fluid resuscitation, if a patient is already in pulmonema or already in heart failure. It should not be renal and cardiac function. It's not recommended at all. It is contraindicated in patients, of course, who are hypovolemic or with obstructive uropathy, because they have reversible contributors. Diuretics for patients with tumor lysis today is but the loop diuretics we use is furosemide. It's the preferable one. Why? Not only because it's induced the diuresis, but also it aids or perhaps for the potassium secretion and moving diet. Okay, moving now to a common practice for TLS. Now we are seeing patients, seeing colleagues, or they are using actively the urinary alkalization study. But honestly, if urinary alkalization is unclear and controversial, the rationale behind it, if you remember, that the urine pH down to 7 or to increase the uric acid sending the urine acid precipitation, but the guidelines and the evidence says it's no longer recommended. Why? First, because of risk of metabolites. Second, it increases the calcium phosphate precipitation. Third, it promotes calcium binding to albumin, which is very important, and it will contribute to hypocalcemia. There is a lack of clear evidence of benefit for the past 10 years behind the urinary alkalization. Most importantly, the feed solubility is poor regardless the pH, and this is uric acid. So the solubility is poor regardless you have the pH down or not. And this is the graph which show that the poor solubility of that range you brought it 4.5, 7.5 is almost a low solubility compared to alanine. It's high solubility with orthosandins. So the end product or the byproduct anthines is very poor with whatever the pH. So we detect that the urinary alkalization is no more in TLS. Continuation of case number 2, okay, you remember him was placed prophylactic measure. So the diagram contain IV flow station running at 3.1 liters as the recommendation of the guide. Electrolytes slightly increased. The current urine output was maintained around 1.3 per kg per hour. What's the next step in Mr. P prophylactic strategy? Now I'm talking about that strategy. To increase the allopurinol to 400 twice daily, to add loop diuretic to promote diuresis, to begin bicarbonate drip to facilitate the urine alkalization, this rest per case. So those for all submit on please. Okay, so from the guidelines, we have the treatment algorithm for prevention and management based on the risk of the tumor lysis. So then you have to evaluate risk. Is there low risk, intermediate risk, or risk? If the patient is low risk, so just, it will have if the patient, now I'm talking about the hyperuricemia. If the patient is intermediate risk, so here is the tool for the patient management with allopurinol. While the per case may be considered in the initial management in racine develop here, you have to start the case therapy. I will show you what the recommended from the guys. For high-risk patients, here the hydration is the cornerstone plus the managed with respiratory. There is no role for allopurinol in high-risk patients. So the role for allopurinol is for intermediate risk, and here we respiratory, while for high risk we have fluid plus respiratory. So those are the three common on that we have: hypouricemic agent, the allopurinol, the respiratory, and this oxidase inhibitor. This is the side of allopurinol on the then same days. So this is the role of allopurinol. It should be initiated prior to radiation. Usually it's a 10 milligram kg per day given in the guided dose. The maximum should be 800 milligram. It reduces the release of we call purine-based therapies. The drug of prophylaxis in patients with intermediate risk of tumor lysis. So there's no role for allopurinol in high patient, and you should be aware about hypersensitivity of allopurinol. About the respiratory, this is the role of respiratory. It acts on uricase time, so it dissolves already the uric acid in allantoin, which is highly soluble in the urine. So this is a recombinant uric oxidase. The dose is either weight-based or fixed dose. It is PD as it may induce severe methemoglobinemia and hemolytic anemia. So if you are not aware about the background of your patient, it may be disaster. So before giving the respiratory, you should patient for, or before you bribe or you consider the respiratory, you should screen your patient for G6PD deficiency. The same like COVID screening, or we're using hydroxy for in the COVID. So hydroxychloroquine. So we were checking for G6PD deficiency. The same for respiratory. So this is the second drug of hydroxychloroquine. The respiratory, it's contraindicated to use with CPC. Effective, acting rapidly in decreasing the urine acid concentration. Actually, with 4 hours, it's very effective. It's advisable, and the only issue is the cost. So comparing the allopurinol versus the respiratory, decreasing quickly or time related for uric acid level in terms of within serum uric acid compared to the, of course, here according to the graph or the practice, it may take days into 4 or 5 days. First per case, there is no study shown its impact on AKI prevention. There is no detail. The British guideline recommended those of 0.2 milligram per kg per case. However, a dose of 3 milligram single administration followed by close monitoring being proven and efficient. So we have two regimen, either fixed dose or weight-based. There is the same guideline, the use of respiratory, tablet, not a mention of this, and prevention only on risk. So those are the two indications. Your patient is categorized as a high risk and intermediate with hyperuricemia, or there is already established tumor lysis syndrome, so should you use the case. And this is the dose comparison, either fixed dose or weight dose. This was a study in 2013. They compare single dose of 3, 6, or 7 compared to the weight times for 7.5, and they found that the 6 milligram was effective. The rest of the 6 to 3, and either those are fixed or weight-based, but they found 6 milligram was effective of the rest. And this was the study comparing renal, the fixed dose weight per kg, and imagine the cost of the rest per kg. So it's costly. It's available. We are one of these cancer centers in the kingdom, so we have it already on board. But you can imagine the cost of the rest. But it's really one of the effective medications in managing tumor lysis with hypersemia, especially the medium and the high. Recommended dosing of risk per case based on rest and the uric acid level, and this was the dose per kg. Third hyperuricemic is recently available, which is called Epidemiology. It's a selective inhibitor. It's actually different from allopurinol. It's highly potent, reducing the uric acid concentration. There is low rates of hypersensitivity compared to allopurinol. It's safe when used in the context of renal dysfunction due to its metabolism. The problem with allopurinol, you should modify the dose in patients with renal. But for Febuxostat not need adjustment. It ameliorates the oxidative stress as well as it would reduce the inflammation. So it's considered as one of the scavengers, and it enhances also the sensitivity. It's a significant kidney patient with CKD or chronic kidney disease. We use the Febuxostat, delay the CKD, improve dysfunction of this patient. There is a growing interest since 2018 and 19, medication prevention of lysis, but it didn't come yet into a recommendation or a guideline. There is several study stating its effectiveness. No firm consensus, as I mentioned, concerning whether it should be considered as a or this study address the role of Febuxostat, its design and the results. Here, this is a article in February 2019, just recent, about a meta-analysis of the use of this Febuxostat prevention of lysis, and this meta-analysis suggests that the Febuxostat may serve as an effective alternative to in prevention of tumor growth. So here, just a summary for the use of our patients, the allopurinol or other case, and tumor and to the exact order of level pregnant cells is the soil hyperphosphate. The restricted phosphorus for the patient is formulation. Usually, when we have a phosphate bind, we need some. When you have a refractory hyperphosphatemia, it's usually a renal therapy, especially if you have hepatic hypocalcemia or the calcium phosphorus product at least 7 per deciliter. Here for the hyperkalemia, I know all about managing the hyperkalemia. It's not necessarily tumor lysis, the management, but the hyperkalemia development and tumor lysis, especially interest, the acute management of hyperkalemia, multimodal approach. I'm talking about hyperkalemia, So it's a model approach, isogluconate, inhaled albuterol, insulin, glucose, bicarb, and resin. But I put cation exchange resin at the end because it's slowly acting. The refractory hyperkalemia will require the initiation of breathing therapy, and this is the cornerstones of managing the hyperkalemia. We have focus membranizers, shifters, secretors, and definitive, which is the hemodialysis. The membrane stabilizers, the calcium gluconate, the shifters are enzyme and albuterol, and secretors are fusimide, sodium bicarb, and cation 1 for hyperkalemia dialysis. Just to highlight one is regarding the sodium polystyrene or the cation exchange resin. Please, you should not, because the onset of action is more than 2 hours and the duration for 6 hours. So to manage with cation is not recommended. It's here, those are the shifters, and the excretors are like fusimide are shorting the sodium bicarb, and of course the cation exchange resin 2 hours, while also the sodium bicarb, unless there is a significant metabolic acidosis, pH1, it's highly recommended. And the definitive, especially for refractory hyperkalemia, is the dialysis. You can see it results from the crystallization with serum phosphate or serum phosphorus. So there is a risk of patient in mainly this. You should use or supplement wisely, and is not indicated if the patient is asymptomatic, because as we mentioned, the risk of precipitation was fast. It will be managed by the control mainly of serum phosphate. So if you control the hyperphosphatemia, this is withdrawal the hypocalcemia. So please do not rush for correction of asymptomatic hypocalcemia. Your correction, your cornerstone, your focus will be on the hyperphosphatemia unless the patient is symptomatic, so with seizure or with cardiac arrest, long QE. So at that time, or tetanus, at that time you have to, otherwise you should not focus on hyperphosphatemia. What about the role of dialysis or renal replacement therapy? The indication of renal replacement therapy, tumor loss, is the same, are the same any other disorders requiring dialysis. There is no sense about which the best modality, RRT or renal replacement therapy, either CRRT or intermittent hemodialysis. There is only conventional hemodialysis should be used for hyperkalemia if the patient is hemodynamically stable. While they found the comparison of CRRT versus intermittent hemodialysis, even hemodynamically stable patients with tumor lysis, they found some benefits for the CRRT. Why? Because ongoing liberation substances from the lysing cells, so intermittent hemodialysis will not be effective. CRRT continuous for 48 hours is better. A prevention of rebound imbalances, and this is okay with the CRRT. And the phosphorescence is a time dependent. So with intermittent hemodialysis, 3-4 hour sessions is not, but the phosphorus is better with RRT or continuous therapy because it's a time dependent. The continual dialysis is not recommended. You continue the dialysis until adequate recovery of the function, resolution of all electrolyte imbalances. Early hemodialysis immediately, followed by continuous or CRRT or prolonged hemodialysis might be indicated or might be used. So use if the patient is stable, and then you continue with CRRT or prolonged hemodialysis like other modes like SCAF. So this is another case, number 3, a 22-year-old female admitted to the hospital with new diagnosed EML. The white count was 29,000. Her electrolytes were within normal. It was 7.1. She is determined to be intermediate risk for the tumor lysis based on the count and the uric acid level, and started IV fluids. Of note, she doesn't have G6PD deficiency, the question is, what should be the next step? To give per case, weight-based dose, 0.2 milligram G, give us 6 milligram dose. You will order G6P thing, start alone. You hold the anti-hyperuricemic treatment and you will titrate fluids to goal urine output. Back to the scenario. And this is the options. For this, please, on the chat. What about the role of ICU and tumor lysis management? The role, of course, of the intensivist in the management of high-risk tumor lysis is primordial. It's very important to be aboard as an intensivist and to have a collaboration with your oncology or hematology colleague if you have patients at risk of immediate or high-risk tumor lysis. Oncology hematology patients at risk of tumor lysis should be preferably admitted to the ICU before the onset of organ failure, of course. And we mentioned there is certain, especially need an ICU who those having AKI, patient with borderline cardiac function, patient who are already edematous. Tumor lysis management protocol should be available. Who should be managed in the ICU? Who should be managed in the ward? What the criteria to admit to the ICU? How can you manage this? How can you manage the intermediate? How can you manage the high risk? And then how can you manage the complications? Chemotherapy, of course, can be safely administered or started in the ICU under monitoring. The close monitoring of tumor lysis patients in
Dr. Adel, still have many slides or because of time?
Just 2 or 3 minutes more.
Okay, please.
So it will include 6-hour measurements of serum potassium, calcium, phosphorus, urea, creatinine, acid, the close collaboration between the intensivist, the oncologist, and the hematologist. There is a called cooking strategy, especially high-risk patient like AML or non-Hodgkin lymphoma. So in AML patient with high W count, there is a debulking strategy, which is there is gradually escalation doses of chemotherapy or hydroxyurea in order to gradually lower down the W count before the intensive chemotherapy. I will come up with some home messages. This is a reminder about the workshop definition of the tumor lysis based on the metabolic abnormality. And we have 2 types, the laboratory and clinical. And this is the risk assessment based on the type of the malignancy, either low risk or intermediate risk or high risk. And these are the cornerstones of the lysis management. Monitoring of the electrolytes, monitoring of serum creatinine, monitoring of the cardiac status and the hemodynamics, monitoring the uric acid and the fluid balance, and the urine output. And these are the principles. This diagram showing the principles of tumor lysis management for fluids, for the hyperuremic agents, and the role of renal replacement therapy. And of course, we have to avoid the treatment of hepatic hyperemia and do not give urinary alkalization. A lot, and I apologize if I extended my time frame. Thanks to Mohammed, thanks to Trolley.
No. Thank you, Dr. Adel. Very informative lecture, really very, very nice and very valuable. It is easy to have a patient to TLS, then you admit that patient to the intensive care. You know that he is a TLS patient. So you have your time frame to categorize and so and so. But my comment, there are 2 comments. First of all, are you hearing Dr. Adel?
Yes, yes, of course.
One comment, you have a patient in the ICU, patient with malignancy and in sepsis, and all of a sudden, when you do his investigation lab results, his AKI, he has hyperkalemia, hyperphosphatemia, all that. Which is first? If the AKI is the cause of this laboratory abnormalities, or this laboratory abnormalities is the cause of the AKI due to TLS. So how you approach for that patient?
Excellent question, Dr. Mohammed. I mentioned in our slide, especially for cancer center burden of those oncology patients or hematology patients, those should have a very well-written protocol for managing or estimating the tumor lysis, and those, as we mentioned, in the based on the risk factors assessment. So early is the best, and admission of patient to the ICU or a high dependency unit, of course, will follow the protocol based on these criteria for admission. So timing, as you mentioned, is very important. So I predict early, so I can prevent early. Also, I can treat the complication early. Coming to the next question, which is the first, or which is the cause, which is the reason or a cause. It's a result or a cause. I mentioned to Muhammad, yes, I mentioned for patients with AKI and sepsis, plus is neutropenic, and here we don't know exactly if this tumor lysis is a result of sepsis-induced AKI or TLS in the TLS AKI. So we have some data and we have some surrogate, as I told before. If I have surrogate from the start, I know the tumor, I know the LDH burden, I know the white count burden. So the patient receives chemotherapy, then he developed the tumor lysis in front of my eyes, though I did not start my management. So here is a TLS induced. Though, if the patient is septic, it's one of the aggravating risk factors. Also, I should address it and put it in mind, the hypotension, the not only the sepsis, the nephrotoxic medication. If the patient is receiving interest, for example, also, or medications, antibiotics, also should be addressed because those are aggravating factors.
Okay, and the message is that we have to put this TLS in our mind with the patient AKI malignant, whether he's leukemic or myelo or whatever,
exactly.
Hodgkin's or
exactly.
right?
Exactly.
Okay.
Exactly.
Another comment, please. Another comment in the classification, Cairo shop classification, or he said that within, I can understand, within 7 days of starting therapy. Okay, but about 3 days before starting. How can you clarify this? 3 days before starting, develop this.
Yeah. This is Dr. Mohammed. Yeah. It's just early. This is a laboratory definition. This is a laboratory definition. It's not the clinical. So in my mind, if I have those or one of those, 2 or more of those metabolic derangement, the hyperkalemia or the hyperphosphatemia or hyperuricemia, 2 or more. For example, if I have patient having hyperuricemia and hyperphosphatemia, 2 or more, now 2 of them, 3 days before 72 hours, or as you said, this is devoted as a time, or 7 days from the initiation of chemotherapy. So this is the from the yes. So they call it a laboratory definition. Now the patient is labeled as TLS by laboratory. Now we will go for the clinical. Does the patient had symptoms related to this hyperkalemia or not? Here is the clinical evidence.
That, but my question about Yeah, 5 days before, for example, a patient 5 days before I found this lab investigation, I will not put him
Yeah,
in.
agree. Yeah, exactly. This is, they put it like the minimum of, but as you mentioned, Mohammed, if you have, for example, for some tumors or at the bulk, like Burkitt lymphoma, they are rapidly progressive. They can start earlier, and some of tumors actually they may develop tumor lysis even after like 5 or 7 days, even more than 7 days. So I agree with you totally. I should expand my time window.
Regarding if the patient has the main acid-base disturbance or electrolyte disturbance is hyperkalemia, that not responding to any medical treatment, and the patient hemodynamically unstable, he's not unstable. Do I still to give to him intermittent dialysis, or I have to wait for, or have to do chronic, a continuous renal therapy? Hyperkalemia is very,
yeah, exactly.
Why
Yes.
why I ask this question? Sorry, I could continue. Why I ask this question? Because you mentioned the statement of dialysis when if the patient is hemodynamically stable. So I'm giving a scenario, another scenario: hyperkalemia, severe hyperkalemia, and the patient unstable, hemodynamic unstable.
Yes.
Or severe hypotensive.
So,
what do you think about that?
Yes.
Yeah.
Yes. So usually if I have an acute hyperkalemia, and irrespective the tumor lysis or not, now, for example, I have who's having acute kidney injury for any reasons, coming with acute hyperkalemia, and he is, for example, he is septic or he is having obstructive uropathy. I did, but he's not responding, but he's hemodynamically stable. You use all the lines, but the patient is refractory. Now there is the rule of the dialysis or the rule of renal replacement therapy. So as you mentioned, Dr. Muhammad, now if the patient is, it depends if the patient is hemodynamically stable or hemodynamically unstable. Some literature are comparing the use of even the intermittent hemodialysis in patients with sepsis on pressors, or the we call it stuff on pressors, and compare it to the continuous CRRT. While would you call it extended hemodialysis, like instead of like 4 hours or 3 hours, they extended like 6 hours because of the ability of the hemodialysis. But for tumor lysis, the benefits of CRRT, not only for hemodynamics. In our center, we start with hemodialysis, then we continue with CRRT, even if the patient is hemodynamically stable, because of the benefits of CRRT, not only for the potassium, but also for the others, for the phosphorus and for the other.
Okay. Yes. Okay. Thank you, Dr. Adel. We have a question from Dr. Tariq Abdel Masoud. He is asking about how can loop diuretics be used in patient with AKI, although it may increase the serum creatinine, urea, and uric acid.
Exactly.
So why the loop diuretics? Because it's never toxic. Why you are using in such patient? Good question.
Actually, I mentioned in the slides that there is no consensus about which is the best diuretic to be used in tumor lysis to enhance the diuresis or to induce the diuresis. But the literature or the guidelines, they recommended the preferable one is the furosemide, based on its rule for in hyperkalemia. Usually, if you remember, we are not using other like hydrochlorothiazides or other non-loop diuretics for hyperkalemia. So for AKI and hyperkalemia, they prefer using the furosemide. And either, I did not mention in my slides, the protocol, either using intermittent or infusion, it doesn't matter. They found the same. Or giving 8 hourly or drip hourly, it doesn't matter. It's the outcome is the same.
Okay. Any question from the panelists? will be happy, more than happy to. Dr. Adel is here with us. Dr. Walid, Dr. Madi, Dr. Magdi.
Thanks very much.
No, thank you. Okay, I think we'll thank you very much, Dr. Adel, for this informative, really informative. Thank you very much. And we reached the end of our night presentations, our night meeting. Thank you very much. Any comment about anything related to our academy? Or let
yes,
us
please.
finish.
Thanks very much, Dr. Adel Hussain. Thanks very much for Dr. Walid Ali. He already went because different times in Australia, so he's just joining his work now. Thanks very much for moderation of the session, Prof. Mohammed Ibrahim. You're always welcome as moderators and colleagues doing lectures. The last thing, next week, inshallah, Professor Nabil Al-Asqalani is talking about enhanced recovery program, how we improve the patient care. So please be here at 9:00 p.m. Cairo time, and more lectures. I'll always keep you updated with savingLivesAcademy.com and on the Facebook page of the Academy. Please feel free to write your comments, evaluations. You're always welcome. So we finished 5 minutes earlier tonight, so it's compensation for the last weeks. My sincere apologies if we are not really exact with the times, but the only excuse we have is we have very knowledgeable, experienced speakers. We want to get the best out of their knowledge and experience. See you always Saturday every night. Don't forget the early bird registration of Critical Care Ultrasound Conference updates. Thanks very much and see you next week. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullahi. Thank you very much.
Thank you.
See you. Assalamu alaikum.